Now we will go over some of the components that are involved in the care of asthma. And we will also go over some goals of some stepwise approaches and some general principles. There are 4 components of care when it comes to asthma. The first one would be assessment and monitoring. You want to assess asthma severity to initiate therapy, assess asthma control to monitor and to adjust therapy. You would like to schedule up follow-up care. Now, some action steps would be to use severity classification chart, assessing both domains of impairment and risk to determine initial treatment. Use asthma control chart, assessing both domains of impairment and risk to determine if therapy should be maintained or adjusted. You can move it up or down if possible. Use multiple measures of impairment and risk. Different measures accept different manifestations of asthma. They may not correlate with each other, and they may respond differently to therapy. Obtain lung function measures by spirometry at least 1 to 2 years, more frequently for not well controlled asthma patients. Asthma is highly variable over time, and periodic monitoring is essential. In general, consider you scheduling your patients at a 2 to 6 week interval while gaining control, at 1 to 6 month intervals depending on step of care required or duration of control to monitor if sufficient control is maintained, at 3-month intervals if a step down in therapy is anticipated. Assess asthma control medication technique, written asthma action plan, patient adherence, and concerns at every visit. The second component is education. Provide self-management education. So some steps you could do is teach and reinforce. Self-monitoring to assess level of asthma control and signs of worsening asthma. Either symptom or peak flow monitoring shows similar benefits for most patients. Peak flow monitoring may be particularly helpful for patients who have difficulty perceiving symptoms. A history of severe exacerbations or moderate or to severe asthma. Using written asthma action plan, review differences between long-term control and quick relief medication. Taking medication correctly. So you want to make sure that your patient is using a proper inhaler technique and the use of devices. Avoiding environmental factors that worsens asthma. You want to tailor education to literacy level of the patient. Appreciate the potential role of patients' cultural beliefs and practices in asthma management. You will need to develop a written asthma action plan in partnership with your patient. Agree on the treatment and the dose and address the patient's concerns. Integrate education into all points of care where healthcare professionals can interact with the patients. So you want to provide instructions for daily management, whether it's on a long-term medication, if appropriate, and environment control measures. And 2, you want to managing worsening asthma, how to adjust the medication, and know when to seek medical care. Involve all members of the healthcare team in providing and reinforcing education, including physicians, nurses, pharmacists, respiratory therapists, and asthma educators. Encourage education at all points of care. Clinics that offer separate self-management education programs as well as incorporating education into every patient visit. Emergency departments and hospitals, pharmacies, schools, and community settings in the patient's home. Use a variety of educational strategies and methods. The third component that we're going to discuss is controlling environmental factors and comorbid conditions. Clinical activity will be to recommend measures to control exposures to allergens and pollutants or irritants that make asthma worse. As action steps, determine exposures, history of symptoms and presence of exposures, and sensitivities. Advise patients on ways to reduce exposure to allergens and pollutants or irritants to which the patient is sensitive. Consider allergen immunotherapy by specifically trained professionals for patients who have persistent asthma and when there is clear evidence of a relationship between symptoms and exposure to an allergen to which the patient is sensitive. Treat comorbid conditions. Consider especially allergic bronchopulmonary, aspergillosis, gastroesophageal reflux, obesity, obstructive sleep apnea, rhinitis, sinusitis, and stress or depression. Recognition and treatment of these conditions may improve asthma control. Consider inactivated influenza vaccine for all patients over 6 months of age. The fourth component of care would be medications. A clinical activity, select medication and delivery devices to meet patients' needs and circumstances. Action steps. Use stepwise approach to identify appropriate treatment options. Inhaled corticosteroids are the most effective long-term control therapy when choosing among treatment options. Consider domain of relevance to the patient, impairment, risk, or both. Patient's history of response to the medication and patient's willingness and ability to use the medication. So now we're going to talk about some of the goals that are of the stepwise approach. So one of the goals is to maintain control of asthma with the least amount of medication and hence minimum risk for adverse effects. So with that being said, the stepwise approach to the therapy, one of the goals is in which the number of medications and frequency will be increased as needed and decreased when possible. And this is used to maintain the use of the medicines to properly help asthma. Some of the general principles I'm going to mention for all age groups. They incorporate 4 components of care: initiate therapy based on asthma severity, adjust therapy based on asthma control. So incorporating 4 components of care include medications, patient education, environment control measures, and management of comorbidities at each step. Monitor asthma control regularly. Initiating therapy based on asthma severity. For patients not taking long-term control therapy, select treatments that are based on severity. Patients who have persistent asthma require daily long-term control medication. Adjust therapy based on asthma control. Once therapy is initiated, monitor the level of asthma control and adjust the therapy accordingly. Step it up if necessary and step it down if possible to identify the minimum amount of medication required to maintain asthma control. Refer to an asthma specialist for consultation or co-management if there are difficulties achieving or maintaining control. Step 4 care or higher is required for children that are 0 through 4 years of age. Immunotherapy is considered, or additional testing if indicated, or if the patient required 2 bursts of oral systemic corticosteroids in the past year or hospitalizations. So let's talk about ages 0 through 4 years. Consider daily long-term control therapy. Young children are typically at risk for severe exacerbations, yet they have low levels of impairment between exacerbations. Initiate daily long-term control therapy for the following: children who have had more than 4 episodes of wheezing that last past year, that lasted more than a day and affected the child's sleep, and have a positive asthma risk profile, either one of the following: a parental history of asthma, physician diagnosis of atopic dermatitis, or evidence of sedation to aerologens, or two of the following: sensitization to foods, greater than 4% of blood eosinophils, or wheezing apart from colds. Consider initiating long-term daily therapy for children consistently that require a short-acting beta-2 agonist treatment greater than 2 days per week for 4 weeks or more. Children who have 2 exacerbations requiring oral systemic corticosteroids within 6 months. Also, in that age group, you want to monitor the response closely and adjust the treatment. If no clear and positive response occurs within 4 to 6 weeks and the patient's medication technique and adherence are satisfactory, stop the treatment and consider alternative therapies or diagnosis. If clear benefit is sustained for at least 3 months, consider step down to evaluate the continued need for daily therapy. Children in this age group have a high rate of spontaneous remission symptoms. Now let's talk about ages 5 through 11. Some of the key clinical activities would be to involve the child in developing a written asthma plan. So address the child's concerns, preferences, and school schedule when selecting treatments. Encourage the students to take a copy of their written asthma action plan to the school. Even if they attend after school activities, they should provide those to those officials as well. Another clinical activity will be to promote physical activity. Treat exercise-induced bronchospasm. Um, Exercise-induced bronchospasms. You want to make sure that you promote physical activity so that they can begin to live normally. Assess possible benefit of treatment in older patients. Okay, so you want to establish reversibility with a short course of oral systemic corticosteroids. Adjust medications to address coexisting medical conditions common among older patients. So now I'm talking about the ages 12 and older. Consider, for example, calcium and vitamin D supplements for patients who take ICS and have risk control for osteoporosis, increased sensitivity, side effects of bronchodilators with increasing age, increased drug interactions with theophylline, medications for arthritis, hypertension, or glaucoma. Beta blockers may exacerbate asthma. That's good to know. Another one would be exercise-induced bronchospasm. A key clinical activity will be to prevent an exercise-induced bronchospasm. Some treatment strategies to prevent this would be long-term control therapy. Treat yourself before exercise with a short-acting beta-2 agonist, or chronic use of long-acting beta-2 agonists for pre-treatment. Well, that is typically discouraged as it may disguise poorly controlled persistent asthma. A warm-up period or a mask or scarf over the mouth for cold-induced asthma. Okay, pregnancy is one that people rarely even think about, but it happens. You want to maintain asthma control through pregnancy as well. You can do this by monitoring asthma control during the prenatal visits. Asthma worsens in 1/3 of women during pregnancy and improves in 1/3. Medication should be adjusted accordingly. It is safer to be treated with asthma medications than to have poorly controlled asthma. Maintaining lung function is important to ensure oxygen supply to the fetus. Albuterol is preferred, and it's preferred as a short-acting beta-2 agonist. ICS is the preferred long-term control medication. Budesonide is preferred because more data are available on this medicine during pregnancy. Now, surgery. You can reduce the risk of complications during and after surgery. This is what you do. Assess asthma control prior to surgery. If lung function is not well controlled, provide medication to improve lung function. A short course of oral systemic corticosteroids may be necessary. For patients receiving oral systemic corticosteroids during 6 months prior to surgery, and for selected patients on high doses of ICS, give 100 milligrams of hydrocortisone every 8 hours intravenously during the surgical period and reduce the dose rapidly within 24 hours after surgery.